My name is David Armstrong, and I'm the Director of the Health Workforce Tactical Assistance Center. Welcome to our event today. Today's webinar is entitled Supporting the Frontline, Strengthening the Community Pharmacy Workforce. Let me go ahead and introduce today's moderator. Today we're joined by Peggy Odegard, a Vice Dean and Professor at the University of Washington's School of Pharmacy. Peggy?
Thank you, David. It's my pleasure today to moderate this discussion about strengthening the community pharmacy workforce, along with my colleagues, Dr. Jennifer Bacci, Associate Professor of Pharmacy, a pharmacist, and an affiliate investigator for the University of Washington Center for Health Workforce Studies, and Dr. Ryan Oftebro, Principal and Chief Executive Officer of the Kelly Ross Pharmacy Group, a pharmacist in Seattle, Washington. The goal of this webinar is to provide an overview of the role of community pharmacy teams in healthcare and public health, presenting emerging evidence about the community pharmacy workforce. This session will focus on practical insights into current workforce issues and strategies to collaborate to support community pharmacy teams and how they can better serve their communities. I'd like to start with just a little background to help those who are less familiar with community pharmacy about what it is and who utilizes community pharmacies. Community pharmacy is actually the most common type of pharmacy practice along with hospital pharmacies. Community pharmacies are highly accessible, located in urban, suburban, and rural areas. And on average, there is one pharmacy within a 10 to 20-minute drive across the contiguous United States. In addition to location accessibility, hours of operation are also quite broad, with hours ranging from 8 to 24 hours daily up to 7 days weekly. Probably, I would say the average is 10 to 12 hours a day for open hours for community pharmacies. The other thing that ranks community pharmacies as an easily accessible healthcare center is that appointments are not required for most of the care services. Community pharmacies are in many different types. There are independent community pharmacies, which are often locally owned. There are chain pharmacies, which can be large chains owned at the national level, or smaller chains owned at the regional or local level. There are grocery store pharmacies, online pharmacies, and even some of the outpatient pharmacies you see near health systems are considered community pharmacies. Thinking about who works in community pharmacies, I think, is quite helpful. It's actually a highly specialized team of professionals working in a community pharmacy, inclusive of pharmacists, pharmacy technicians, and in some states, pharmacy assistants. A little background on those professionals: pharmacists complete a 4-year clinical doctorate training degree, inclusive of training on assessment, diagnosis, prescribing, and monitoring, with the focus being on medication-related care. Pharmacists may complete residency or fellowship training. That's currently optional, although the rates of those people completing training is increasing, and the number of employers now looking for residency-trained pharmacists is also increasing. Pharmacists take 2 national board exams for licensure, and they may also, at some point in their career, complete specialty board certification, with probably the most common certifications in community pharmacies being the BCPS, which is the board certification in ambulatory care pharmacy, diabetes education specialty certification, or general board certification in pharmacotherapy. Pharmacy technicians are another critical member of the workforce, and actually take the lead on much of the pharmacy operations and client support in community pharmacies. Training varies per state, and it can range from on-the-job training in the pharmacy to formalized education and coursework and experiential education through at the college level. There is a national certification exam for pharmacy technicians, although that is currently optional, but a number have completed it. Next thing to think about is who utilizes community pharmacies. And many of us on this call have probably utilized or walked into a community pharmacy, and it can the things that people are seeking are most common that we think about as prescription fill or refill services, but there are also a number of other services being offered that the public is seeking, including many clinical services such as initial medical assessment and triage for something that might be going on medically. Advice for self-care that can be included as part of that medical assessment and triage, education, clinical care services such as chronic condition management or test to treat, health promotion services such as travel vaccines, health screening services such as blood pressure screening or monitoring. And another group that utilizes community pharmacies, which we often don't think about, but can definitely be a part of the day in the work of a pharmacist, is health professionals in their communities reaching out to consult with them regarding treatment planning for patients. The scope, impact, and possibilities for community pharmacists are quite broad. Just to leave you with a summary here, there are 67,000 community pharmacies in the United States. Almost 90% of individuals living in the US live within 5 miles of at least one pharmacy. Pharmacies in the community are currently meeting several public health critical services, such as immunizations against vaccine preventable diseases, HIV pre-exposure prophylaxis, hypertension screening and management, overdose prevention and treatment, and reproductive health care. And I want to turn now to my colleague, Dr. Jenny Bacci, to help us understand the workforce research that we've been doing, but leave you with a quote from a report to the Surgeon General 14 years ago in 2011. And that was highlighting that pharmacists are well positioned due to their accessibility, expertise, and experience to play a much larger role in primary care in the US healthcare system. And I think what we'll as we look at this workforce data, that's one important thing for us to think about is what is the role of pharmacists currently, what can it be, and where do we go from here? So with this, I'd like to turn it to my colleague, Jenny Bacci. And Jenny, I'll go ahead and run the slides. Just let me know when you would like me to flip to the next one.
Thank you, Peggy. Really appreciate the introduction and background on community pharmacy. It's my pleasure to be here to speak to some of the research that we're doing on this important workforce. If you'll go ahead and go to the next slide, Peggy. The research that we are doing has been through our Center for Health Workforce Studies at the University of Washington, UW-CHUS, which is a health workforce research center. And it has been in collaboration as well with the school pharmacy at University of Washington. We have 2 of the health workforce research centers, Allied Health, which is the center through which we're doing our community pharmacy research, and also Health Equity. Next slide. There are a number of health workforce research centers across the country, in fact, 9. And so here are a list of those in case you're interested in the additional health workforce research that's going on across the country. Next slide. But again, today we're here focused on community pharmacy. And the story of the research that we've done really starts with the COVID-19 pandemic and the impact that community pharmacy had. In the first 18 months of the COVID-19 vaccination campaign, pharmacists administered over 270 million COVID-19 vaccinations. They also collected over 42 million COVID-19 specimens for testing and administered over 100,000 doses of monoclonal antibody treatment. And that was just during the public health emergency itself. And that's a huge amount of workload. And we wanted to be able to tell the story of what that looked like for the community pharmacy workforce. Next slide, Peggy. And so our goal was to describe the community pharmacy workforce response to the COVID-19 pandemic. And we did that by conducting interviews with community pharmacy and pharmacy association leaders from across the US in the first half of 2022. Next slide. And what we found from conducting those interviews, we found that there are many important functions that the community pharmacy workforce fulfills. And Peggy shared a lot of that in her introduction. And during the COVID-19 pandemic, a lot of the workforce effort really transitioned to fulfilling the COVID-19 response needs. So in addition to continuing to ensure access to medication, they were focused on COVID-19 testing and COVID-19 vaccinations. And one of the reasons that community pharmacy workforce was so successful in helping respond to COVID-19 was because of the profession's history as immunizers and the number of scope of practice expansions that happened during the public health emergency to facilitate their ability to respond. And I have here two of the quotes that our participants shared that I think are just very powerful to what was going on in community pharmacy at the time. There isn't one industry that could have responded in the way that community pharmacies responded. States that went all in on pharmacy early had an easier time rolling out the COVID-19 vaccine and doing it at a pace that mattered. And what our participants shared was that because pharmacists had been administering vaccines in some states like ours for over 30 years at that point, they were able to stand up doing mass vaccinations really quickly. They were also able to do it because of the scope of practice expansions. And one of those expansions was allowing pharmacy technicians across the country to help administer vaccines. So another participant said, I have a technician that became certified to administer vaccines. It's really freed up time, and we would have never been able to do as many vaccines as we would have done without technicians being able to administer vaccines. So while the pharmacist was still responsible for doing the assessment to ensure that the patient was an appropriate candidate for the vaccine, technicians were able to step in and help with the actual administration of the vaccine. Next slide. Well, there were some facilitators. We also learned that there were some things that hindered the community pharmacy workforce ability to respond fully in the ways that they could. That included workforce shortages and workload increases that ultimately contributed to burnout among the workforce. So the community pharmacy workforce took on a huge amount of new work in a very short time with the vaccines, the COVID-19 vaccines, on top of the additional regular routine vaccines that they were already administering, like the annual flu shot, as well as the testing, and in some cases also administration of a monoclonal antibody. And while they were taking on that work, a key part of the workforce, pharmacy technicians, were also going through training to learn how to administer. One participant said, we're always chronically low on trained pharmacy technicians. With the opportunity for technicians to administer vaccines, the timing was not exceptional because we were asking them to do training while working exceptional number of hours in a very stressful environment. So what this participant is saying is not that pharmacy technicians shouldn't administer vaccines, but it would have been helpful if that training could have happened before the pandemic rather than trying to do it in a time of high workload. Another participant said it's the need to receive payment for services. We wouldn't be on such thin margins. I think well-being would be better because we can be appropriately staffed. And finally, we learned that maintaining the community pharmacy workforce readiness is critical to future emergency preparedness and response. And so a lot of our participants talked about what we can do to not be in a similar situation in the future. If we find ourselves in another public health emergency, how we can mobilize community pharmacy and not have to go through the additional steps of training and scope of practice expansion, but rather really take advantage of the skilled workforce and what they are good at. One participant said, the goal is to secure those gains that were extended under the PrEP authority. I know the emergency authorization is still in effect, but it won't always be. It's really imperative to make sure that there can be consistency in the delivery of services throughout the country. Next slide. And so the implications from this study, I think, highlighted what a lot of us already knew, that the community pharmacy workforce embraced new roles to address public health needs, but that they faced delays because of some of the temporary scope of practice expansions and reimbursement pathways that had to be established during the emergency to facilitate the care that the community pharmacy workforce could provide. And so as we think to the future, how can we ensure the community pharmacy's workforce capacity to respond to future emergencies? And that includes identifying opportunities to institutionalize those policies and resources that proved essential during COVID-19, and ways to maximize that professional satisfaction among the workforce to ensure resiliency and a strong workforce. One of the key things that came up in our COVID-19 research was the pharmacy technician and how critical they are across the pharmacy workforce, but particularly in community pharmacy, because they were in a position where they were able to step up and help fulfill and ensure that we could vaccinate the public. And we also heard that that was a challenge because it's a struggle to fill pharmacy technician positions. And so from that study, we started to ask the question of how can we strengthen pharmacy technician career pathways across practice settings, so in community pharmacy, but also in hospital pharmacy. Next slide, Peggy. So as I mentioned, pharmacy technicians are a vital member of the pharmacy workforce, and demand for these professionals has been high across all settings. And so our goal was to look at how we strengthen those pathways, including how pharmacy technicians enter their careers, how they are recruited and retained, as well as how they advance professionally throughout their professional journey. And so once again, we conducted key informant interviews with pharmacists and pharmacy technicians from professional organizations, community pharmacies, health systems, and researchers already working in this space. Next slide. Regarding career entry, what we heard from our participants were that primarily pharmacy technicians select that pathway because they have an interest in healthcare and they had prior exposure to pharmacy technicians in the role of pharmacy technicians. One participant said, the pathway I see most common is they have a family member that is working in pharmacy. It's also a great entry point for anyone who's interested in healthcare in general. That's also a very common entry point for pharmacists, so commonality across the community pharmacy workforce. However, variation in the quantity of entry-level requirements can impede entry into pharmacy technician careers. So entry requirements are set within state regulation, and that varies highly state to state in the United States. One participant said, I absolutely think uniform requirements are needed. There are so many points of entry that one can get lost. I think uniform standards starting within training would be step one. And finally, regarding career entry, we heard that proactive promotion of pharmacy technician careers are needed. So often is it about the pharmacist as the professional and less about the pharmacy technician as a critical element and how those two professionals work together as a team. I really think that just making sure you take care of the existing technician workforce you have, because word of mouth is probably the most powerful recruiting tool. There's a lot of power in just doing the right thing by your employees, creating a positive work environment that people want to come work for. Next slide. Regarding recruitment and retention, our learnings here really revolved around pharmacy technician compensation and how it's no longer aligned with the job demands, particularly as technicians' roles continue to expand, for example, with COVID-19 vaccine administration and administration of other vaccines. Many of our participants in this study specifically use the example of that they're competing with fast food companies, and often, in many circumstances, workers in fast food chains are able to earn more than a pharmacy technician. One participant said, I think pay is another. Minimum wages have gone up in a lot of jobs. I don't know that we are seeing an equivalent increase in being a pharmacy technician. Many of our participants talked about career lattices or ladders as an opportunity around compensation to help create advancement opportunities for technicians. And while it was identified as a solution, it also, many of our participants talked about how that is more feasible in certain environments rather than others, like the larger organizations, the healthcare systems, the chain pharmacies, where there is opportunity for upward mobility. versus in an independent pharmacy where it's one location, and how it can be a bit more challenging because there's only so much upward mobility for everyone, but how there's still opportunities in that environment to help pharmacy technicians find fulfillment and advancement opportunities in their role. Next slide. And finally, professional advancement. Many of our participants spoke about the pharmacy technician professional identity being a challenge because, again, so much of their work is defined by the pharmacist rather than the role of the pharmacy technician themselves. One pharmacy technician said, if I could change anything right now, it would be the lack of perception of the professionalization importance of the pharmacy technician. To begin with changing the perception, we need to remove the lens that it's all about pharmacists. And one of the opportunities that was identified that could help with that is, again, looking towards scope of practice and policies that can help facilitate pharmacy technician advancement. Many of the regulations state to state dictate what can be delegated to a pharmacy technician. And as you might imagine, there's a whole spectrum of that across the country. But what we're starting to see in some leading states is a movement towards being able for the pharmacist and the pharmacy technician to make that decision together based on the technician's education and training. And that model is very similar to what we see in physician practices and what they're able to delegate to their other team members. Next slide. Through this study, we learned that there's emerging opportunities that we as a profession and as a workforce need to look at to continue to ensure that we're able to fulfill pharmacy technician positions across pharmacy settings because they are an essential member of our workforce. And those strategies really boil down to cultivating the pharmacy technician professional identity, creating career ladders and lattices or professional advancement opportunities in ways that make sense based on each organization, addressing low compensation, and advocating for regulatory approaches around what can be delegated to pharmacy technicians and their functions. The final study I want to share with you today was looking at another member of our workforce that we haven't really talked about, and that is our future pharmacists, our pharmacy students. We often refer to them as interns because many of them work in pharmacy, whether health system or community, during their time in school. And right now is an interesting time for us because we had been preparing for an expected surplus of pharmacists, and over the last few years have really seen that transition. Next slide, please, Peggy. In the early 2000s, we were coming out of a shortage of pharmacists. And in response to that, we saw a rapid growth in schools and colleges of pharmacy across the country to where we're at now, which is around 140, as well as the expansion of class sizes within existing schools and colleges of pharmacy, which had put us in a position of expecting to once again be in a surplus of pharmacists. But there have been a number of factors where we now find ourselves in a position of finding decreasing applicants and application to schools and colleges of pharmacy. Some of that certainly was COVID-19, as we've seen across various health workforces. But another unique factor in that is the evolving role of the pharmacist. We are predicting a small but increase in demand for pharmacists, primarily in their evolving role supporting patient care and medication management. And so this study, we really wanted to explore what was driving these declines in pharmacy school applications from the perspective of the students who are making the decisions themselves. So undergraduate students, as they're making that decision about whether to enter into pharmacy school. So we did this by conducting a web-based survey in partnership with 5 different universities from across the country that all have a school or college of pharmacy. Next slide, Peggy. So here you see just some basic demographics of our 94 survey participants, including age, gender, and race and ethnicity. Along the top, you'll see that we divided our survey respondents. We asked them to identify whether they had already applied to pharmacy school or were intended to apply to pharmacy school, or if they were still in that decision-making process, because we were intrigued to see if these looked a little bit different. And so as we would expect, our participants were younger, early 20s. Most pharmacy students do 2 to 4 years of undergraduate coursework before entering their doctorate training program. Overall, we also had about 80% females, which is slightly higher than what we would expect, but the pharmacy profession does tend to have a misbalance of gender, and right now tends to be about 70 to 30 female in general. Next slide. So I'm going to share some select results because we asked these participants a lot of questions about factors related to their decision. We asked about things related to the education and training of pharmacists themselves, as well as the experiences and advice that the students had received. So in this chart, you're seeing their responses about factors related to education and training of pharmacists. And we asked them the extent to which these factors influence their decision, positively or negatively. And again, we have this divided based on those who had already applied or intended to apply and those who were still deciding. So the blue bar that you see on top are the students that were undecided and still in the process of deciding. And the green bar that you see is those students that had already applied or planned to apply. The more bold color indicates that it was a positive factor, whereas the more translucent the bar becomes means it became a negative factor or did not influence their decision at all. And what we see here is that the prestige of the doctorate degree was the highest positive factor for both groups. Whereas on the other hand, pharmacy school tuition was a negative factor, and the most negative factor across all the items that we asked about in terms of their decision to study pharmacy. Next slide. We also asked about their experiences that influenced their decision to study pharmacy. And again, here you see these responses split between those who have already applied versus those who are still deciding. And what we found, similar to what we had learned with pharmacy technicians, is that enjoyment of science and healthcare is part of what goes into people's decision-making process in terms of applying to pharmacy school. What we also found in the items that you see in yellow are items that pharmacy schools have traditionally relied on for recruitment, like pre-pharmacy clubs and organizations or previous pharmacy work. We found that those were more moderate in terms of their influence for pharmacy students. Particularly surprising to me that social media did not seem to have as much of an impact as we've seen a rise in the use of social media across the pharmacy profession. And as we're seeing schools and colleges of pharmacy engage with social media differently. But it may be that we're just a little bit too early and may see that effect coming in the future. Next slide, Peggy. So what we learned from this study, because this is certainly not the first time that we've asked undergraduate students about intentions to apply to pharmacy school. And there's a lot that remains the same: enjoyment of science and the ability to work in healthcare and support people's lives positively. But what was new was the pharmacy school tuition. We are seeing significant increases in pharmacy school tuition and the burden that comes from that. Over 80% of PharmD students are having to incur debt in order to attend pharmacy school. And so there are opportunities for pharmacy academia to look at additional opportunities to support needs such as scholarship, tuition discounting, and revenue stream diversification. Next slide. So as I wrap up my comments, if you go to the next slide again, just want to leave you with where we're taking our research next, and that's really into community pharmacy closures. This is something that many of you have probably heard about across social media or news media, and that is the number of pharmacies that are closing across the country. And we are rapidly learning about the impact of these closures on terms of access to care and their impact on health outcomes. And what we also anticipate that these closures are going to have an impact not only on the community pharmacy workforce itself, but the broader pharmacy workforce. And so we're going to be looking at community pharmacy closures from that perspective of how the connection with the workforce itself. So with that, I will close my remarks and pass it off to Ryan Oftebro. Before I do, just want to acknowledge our research team and our funding from the Health Resources and Services Administration. Thank you.
Thank you, Jenny and Peggy. My name is Ryan Oftebro. I am a pharmacist of over 20 years, graduate of the University of Washington School of Pharmacy, where I'm still on clinical faculty. And I am the CEO of Kelly Ross Pharmacy Group. Kelly Ross is a pharmacy in Seattle. It was actually established in 1925, so we're celebrating our 100-year anniversary this year as a pharmacy. And I'm actually a second-generation pharmacist. My father is a pharmacist, and he owned Kelly Ross from the early 70s until mid-2000s when he brought me on as a partner and he retired, and I now have 3 partners. We have 5 locations in Seattle. We cover a broad range of services within community pharmacy. We have a clinic-based pharmacy. We have a compounding pharmacy. So compounding is the customization of medications for specific patient needs. We have a pharmacy that is inside a clinic where we provide clinical services under a collaborative drug therapy agreement, and I'll explain that in a moment. And then we also operate a couple of long-term care pharmacies. So broad spectrum of services that goes beyond just dispensing medications. These are actually some images from some of our different pharmacy practices, and our pharmacists were involved early in the COVID-19 vaccine distribution. We received 1,000 doses in some of the early days of the vaccine, and we were able, as Jenny alluded to, we were able to pivot very quickly, and we're able to stand up a mass vaccine clinic within 48 hours, immunizing healthcare workers that didn't have access through a health system. We also were the first community pharmacy, I believe, in the country to receive Mpox vaccine a couple of years ago when there was an outbreak in the Seattle area. And so those are our pharmacists that are preparing to start the Mpox clinic. Let's see. I mentioned collaborative drug therapy agreements. This is actually a way that pharmacists in Washington State and around the country are able to provide a wide variety of services through collaborative practice with a prescriber, somebody who has the ability to prescribe drugs. They delegate that authority to a pharmacist. So we're able to do things within the parameters of an agreement that, everybody knows about flu shots in a pharmacy. Well, that's actually done for the most part under a collaborative drug therapy agreement. Other services may include diabetes management or anticoagulation management. In our practice, we provide services such as HIV prevention or PrEP, travel health, hepatitis C treatment, STI treatment, and take-home naloxone. Those are all things that our pharmacists are able to do under these collaborative drug therapy agreements or collaborative practice agreements. Our workforce, just to give you a little context, is made up of pharmacists, technicians, assistants. We also have a community practice residency program. So this is additional training that a new pharmacist graduate will step into our residency program and receive an additional year of training as a pharmacist. but really focus on developing their clinical skills. And that's where a lot of these clinical services have come from, was from outgrowths of our residency program. And then we're also an experiential training site for both pharmacists and technicians. So we have the good fortune of being in close proximity to the University of Washington School of Pharmacy. So we have a number of student pharmacists or interns who do their experiential training with us, both as intern employees as well as folks that are in their different practicums. And then we also provide this for in partnership with one of the technician training programs in the area. So we'll have student technicians that are getting their experiential time within the pharmacy. Another area of community pharmacy that folks may not necessarily think of is long-term care. We have 2 long-term care locations. We provide services to sort of traditional senior living communities, as well as we work with a lot of safety net organizations in the Seattle area that provide permanent supportive housing. We work with a lot of folks that may have unstable housing, and we kind of provide that the adherence packaging to help them better manage their medications in whatever setting they're in. Sometimes we go into the patient's home, as you see one of our pharmacists there making an in-home visit. As for our technicians in long-term care, their roles may cover data entry, working with automation, dispatching our delivery drivers. So it's more than just counting and dispensing pills. And then I think our next slide, if I have it, again, just some of our newer services. We've been providing take-home naloxone under one of these collaborative drug therapy agreements for about 10 years now. This allows us to dispense a take-home Narcan kit to anybody that is at risk of an overdose or at risk of witnessing an overdose. So really covers a broad swath. And so anybody that is interested can carry a naloxone kit. Because pharmacies are so accessible and pharmacists are the most accessible healthcare providers, we felt this was the ideal place to make a medication like naloxone accessible and try and support the public health campaign around overdose prevention. And then we also have our PrEP clinic, which is HIV prevention, pre-exposure prophylaxis. So anybody that is at risk of acquiring HIV can come in, make an appointment with one of our pharmacists, and during a 1-hour visit, they're screened. We do all of their blood work. And then if they're a candidate, the pharmacist actually can prescribe the medication, and then it's dispensed all in one visit. It's super low barrier and has been tremendously successful at increasing access to this service in our community. I wanted to speak a little bit about sort of challenges and opportunities that I see in the community pharmacy. And I will say that all of my real world experiences were validated in Jenny's studies that she talked about. As for the challenges, the biggest challenge right now facing community pharmacy is the business model that we operate in. In community pharmacies, the vast majority of them, they're billing a patient's insurance for those medications that they're dispensing. All of those contracts are through what are called a pharmacy benefit manager, or PBMs. You may be seeing more about PBMs in the news these days. For many, many years, they've kind of flown under the radar, but they are the role that they fulfill is to provide that adjudication of a pharmacy claim. So when a pharmacist dispenses a medication, we bill the insurance. That transaction happens through the PBM. They tell the PBM, they tell the pharmacy, what the patient is to be charged for a copay, as well as what the pharmacy is reimbursed for the drug. The challenge is that due to industry consolidation, there are 3 large PBMs that control over 85% of the marketplace, and they hold all of the contractual leverage. So if a pharmacy wants to bill a patient's insurance, we're forced to take whatever terms these PBMs offer in their contracts. And what we're seeing is, again, this kind of downward pressure on reimbursement for the medications, to the point where in the last year or two, we've really hit a tipping point for many community pharmacies, where what they're being paid is less than they're able to buy the medication for in the marketplace. And so this presents a tremendous challenge. This is the leading factor in the closure of pharmacies, and leading to what Jenny mentioned are these pharmacy deserts. It's happening all over the country. We're seeing it in Seattle. Most of the large retail pharmacies in the Seattle core, where we are, have now closed. We're one of the only pharmacies in the downtown area, and it's creating a lot of challenge. There's opportunities there, but again, the business model is broken to the point where we really need to see some reform on the PBM front in order to fix this. Other challenges we see, with what's happening with salaries and reimbursements, particularly with our technicians. They are increasing in what they're able to do in the pharmacy. We're seeing salaries increase, but again, because we're limited in what we're reimbursed through the PBMs, where basically we don't have the ability to add staff when we need them, or increase salaries or cover other benefits the way that we would like to. And so we're losing a lot of technicians to other industries. They may be choosing tech or other industries where there's more upward mobility, or ability to grow those salaries. Let's see. And then, I mentioned pharmacy deserts, and then just kind of a general burnout that's happening in healthcare is a challenge for technicians and pharmacists. Coming through the COVID-19 pandemic, it took a toll on a lot of community pharmacy staff. It was a very stressful time, and a lot of people have left the industry, and they're just not practicing in pharmacy anymore. And so attracting and retaining people continues to be a challenge. The way that we are kind of meeting those challenges is through innovation. Because of our diverse practice setting, because of the fact that we're offering our team a lot of different ways to practice pharmacy within Kelly Ross, we've been able to continue to be an attractive place for people to come work. So while a lot of my peers in the community pharmacy space are challenged on the workforce front, we've been very fortunate that we've been able to attract and retain really some of the best people in the business, both our pharmacists as well as our technicians and support staff. But we really feel that because of the niches that we've chosen to work in, some of these different services that have a different business model, reimbursement model for these clinical services, it's given us some latitude in how we're able to compensate people. These services such as HIV prevention or PrEP, they're not reimbursed through the PBMs. We're able in Washington State to bill for clinical services on a patient's medical benefit, which is a completely different model than the pharmacy side of things. And this has allowed us to grow these services in a sustainable way. And so that's something that is somewhat unique to Washington State, but there are a number of other states now that have passed provider status laws. And so I think that is going to be a significant area of opportunity for community pharmacies in the future, because I think pharmacy, there's still a tremendous need. And particularly in the public health space, there are things that we can do in pharmacy because of our accessibility and our ability to roll out services very quickly. I think we've got a tremendous opportunity to kind of fill some of those gaps in the public health space. So that's kind of my my future of pharmacy in a nutshell. And I guess I'll turn this back over to the group if there's any questions.
Thank you, Ryan. David, I'd like to invite two of the audience members have questions that you'd like to share. I think we'd be very open to fielding those. And maybe while we're assessing that, Jenny and Ryan, can you speak a little bit more to what's the path forward for community pharmacy? Ryan, you alluded to it a bit with innovation. And Jenny, you certainly alluded to some opportunities to, prepare and ready ourselves for a upcoming needs. Can you speak to that a little bit more, please?
I'd be happy to. I kind of touched on both of these. I think it's two parts. There's the innovation piece, but we also need this reform around the business model. We need both of those things to work together. But I think that is the path that we see and where we see growth. There's certainly a lot of uncertainty in healthcare these days, but that PBM reform, I think, is crucial to ensuring that community pharmacy continues to be a part of the healthcare system. And then within that, our roles are going to change just because the needs of the community is changing and evolving, and that's where the innovation comes in.
I agree with that. I think the future relies on some policy reform, like Ryan mentioned. We have a highly skilled workforce that is held back from what they're able to contribute to patient care and to the healthcare team by what states say they can and can't do, which is often below most pharmacists and for many pharmacists, pharmacy technicians, their clinical abilities and skill sets. I think beyond that, the payment as well, not only pharmacy benefit managers and dispensing, but as Ryan talked about, how we are paid to provide that patient care. Because under the dispensing model, the changes in health outcomes that we can help promote are often lead to increased medication use. And so there's this misbalance of incentives where we've been so tied to the being paid for the medication product itself. However, when pharmacists get involved in care, we know that we improve outcomes, but we need that payment to look like other healthcare providers through the medical benefit. And while many states, we're seeing it growing, and in Washington State, we're fortunate to have the ability to be paid for Medicaid and commercial payers, we need the federal change for Medicare as well, because that's going to have the biggest impact in terms of change across the country.
Thanks. A question that's come in from the audience is, are there partnerships between pharmacy schools and the pharmaceutical industry for growing scholarships or endowments to address some of the educational expense issues? You want me to
Peggy, I
take
think
that
you
one?
maybe are well suited for that one.
Yeah, I was going to say, I'm happy to take it because I've pondered this and worked on it for many years. So yes, and there's a lot of opportunity to continue to think in that space and grow that part of the equation. Many schools are supported well by alumni with contribution to scholarships for students. And some of the businesses or corporations that own pharmacies do extend scholarship support. But you're right, growing those into endowments that's sustainable support over many years is important. But we also have to keep our scholarship support at pace with the cost of living increases that students are experiencing, especially when they're coming to schools of pharmacy in major metropolitan areas where the cost of living is higher. So great question. I think more work is needed in that space. And when you say pharmaceutical industry, I think of two pieces. I think of the field of pharmacy practices, so the companies and the owners of pharmacies, but I also think of the pharmaceutical manufacturing industry, and that's another piece that we really haven't explored. So thank you for that language. Another question is, how is the community pharmacy workforce connected to the greater healthcare system, and what opportunities are available to enhance care through connection?
I'd be happy to answer that from my perspective. I think that in our practice, we have a number of different linkages between our team and the greater healthcare system. And again, I'll give the example of our HIV prevention clinic. This is a low-barrier clinic, and it's really intended for folks that may not already be plugged into the healthcare system. So a lot of times these are individuals that may not have any history with a medical provider and they're seeking care for the first time. Part of our protocol, and we're very intentional about this when we set it up, was that we don't want to be, the kind of the end of the road for folks as far as their care goes. And so we have built into our protocol that you can continue to see one of our pharmacists for PrEP up to a year, but by the end of that year, they need to have been referred out to a primary care provider. And we actually are proactive in making those linkages, so we can help. We know folks within the community, and we can help make those linkages to care. Additionally, if somebody already has a primary care provider or they're in another healthcare system, our pharmacists are actually sharing their notes, making sure that progress notes make it from our electronic healthcare record, and they are connected back to the primary care provider, so there's continuity of care. And so that's one example. We've got multiple other ways that we do that. Also in long-term care, you have folks that are, they may be coming into a place like Downtown Emergency Services Center for their behavioral health. But then we're also kind of providing that coordination between, a primary healthcare provider that's providing some of the care for their other chronic diseases. And the pharmacy is often that hub and connectivity between multiple providers within the community. There's plenty of opportunity to do that a lot better. Technology is a big barrier right now because all of our different systems don't really talk to each other. And so I think that that's a big area of opportunity within healthcare and around policy changes to incentivize these systems to work together in a more seamless way so we can ensure continuity of care for our patients.
Thank you, Ryan. Jenny, did you want to add anything? Yeah, I just want to augment what Ryan said about the continuity of care. I think there's a lot of opportunity. There has been a lot of work over the years when patients are either come from the community and go into a hospital or are in a hospital and go back to their home in the community. They are at high risk for medication discrepancies or gaps in care. Everything from therapeutic duplication with something they have at home to just lack of communication about a treatment, so that treatment is inadvertently discontinued. And community-based pharmacists have done a lot of work over the years to try and make sure they have updated medication regimen lists for patients and that they can coach them and provide education and counseling in support of their health on those medications. But as Ryan just alluded to, our systems don't communicate. So it has its challenges. And a lot of hospital pharmacists then are doing the work to try and make sure patients leave with an updated medication list that they can then share with the community pharmacist to minimize any gaps in care or adverse drug events related to that transition. Alrighty. Well, thank you for your time today. We've really enjoyed the chance to share with you about community pharmacies and the community pharmacy workforce and the opportunities and needs. David, I will turn it back to you for the close of the webinar. Thank you very much, everyone.
Okay, and thank you very much. That was a very interesting conversation. Thanks, Jenny, Ryan, and Peggy.